It is one of the most challenging conditions facing hospitals nationwide. An extreme reaction to infection, sepsis can be unpredictable and progress rapidly, becoming a medical emergency. Here at UT Southwestern, our teams have reworked how we diagnose and treat sepsis, saving more lives every year. Joining us today to discuss the continuing advancements are Dr. Sterling Overstreet, an emergency medicine physician, and Cary Orrick, a performance improvement coordinator for nursing. Thank you both for joining us. Dr. Overstreet, September is Sepsis Awareness Month. Tell us, what is sepsis?
Sepsis is effectively an extreme response to an infection, and something that can start off as simple as a wound or a cough and an early pneumonia can progress to the point where maybe initially you have some abnormal vital signs of fever, a little bit of a fast heart rate, and as that infection worsens, it can actually lead to organ damage, and we can detect that through labs. And eventually, vital signs can actually become more abnormal, blood pressure can get lower, and unfortunately, that can be associated with mortality.
Cary, with symptoms of sepsis, how do you decide whether the patient is septic or whether or not these are symptoms that are attributable to something else that might have brought them to the hospital or to the clinic?
Unfortunately, sepsis does not have its own unique set of symptoms. It can look and mimic a lot of other health conditions. It can help in the screening process if we can tie a risk of infection with a particular set of symptoms, and that can be an elevation in fever, rapid heart rate or rapid respiratory rate, a new onset of confusion, or perhaps an elevation in the white blood cell count. When we can take one or more of those symptoms and time with an infection risk, like a new cough, urinary tract symptoms, or perhaps a draining wound, putting the two together, then we really have to ask ourselves, could this be sepsis?
Dr. Overstreet, how often do you treat patients with sepsis, and do most of them develop sepsis before they get to the hospital or afterwards?
We see sepsis all the time in the emergency department. The overwhelming majority of people develop sepsis in the community, at home, and whenever they recognize that something's not right, they're not feeling well, maybe they have a fever, maybe they have some pain in their side, they present to the emergency department, and we're able to recognize it at that time, diagnose it, and begin treatment.
Cary, are there certain populations that are more at risk for infections and also more at risk for sepsis?
We all bear a certain risk for sepsis, but as we reach the age of 65 and older, our risk goes up. There's an increased risk when we have certain medical conditions like diabetes, kidney disease, lung disease, liver disease, and then we need to have a special concern for our patients who have a weakened immune system. And this could include our transplant population, any patient who's on an immune suppressant, and our oncology patients. And then there's the very young. So children younger than the age of 1 don't have a fully developed immune system and can be at higher risk.
Dr. Overstreet, at UT Southwestern, we've been working for several years to really improve our protocols, our treatment of sepsis, both identifying it and treating it in the emergency department as well as on the units. Tell us about that program and how you've led that.
What we've really focused on is recognizing early that a patient either has an infection or might have an infection, and initiating a workup to either confirm that or point us in another direction. If we do think that a patient has an infection early on, utilizing the resources that we have at UT Southwestern to get antibiotics on board faster, because ultimately we know that this leads to improved patient outcomes. We have a provider in our triage system who is able to listen to the complaints of the patient and make a rapid decision if they think a patient's at risk for sepsis. The nurses are able to initiate workups, and all of this has led to improved outcomes.
Cary, tell us about the importance of nursing in these new sepsis protocols.
It's really the urgency, allowing nursing to have an intervention they can begin when they first recognize symptoms. They can initiate standing medical orders that are pre-approved specific to sepsis that can drive care even before the patient leaves the triage area.
Dr. Overstreet, we were making a lot of progress in improving outcomes with sepsis, and then COVID-19 came, which really added another degree of difficulty to the work of your team. How have you adapted to that?
COVID and its presentation often overlap with the presentation of sepsis, as do many other disease processes. Fortunately, we have rapid diagnostic testing that we can perform in the emergency department to help identify whether or not we're dealing with COVID or whether or not we're dealing with a bacterial infection of some kind.
Cary, why is time so important in treating sepsis?
And research points to a possible increase in mortality anywhere from 4 to 8% with each hour we delay care. So, urgency is a big factor in good outcomes.
Dr. Overstreet, what are the long-term effects of sepsis and what's being done to prevent and improve the outcomes?
Unfortunately, many patients with sepsis require hospitalization. And depending upon where the infection is and what the source is, that can require medical interventions, it can require surgical interventions. In severe sepsis and septic shock, sometimes this requires prolonged ICU stays. And understandably, all of these procedures and these prolonged hospital stays can lead to debility. They can lead to challenges down the road for the patient. Additionally, just the psychological effects of having to go through that and be hospitalized and try and process all of that is certainly a challenge.
Cary, as you look back over the last couple of years and you look at the success of the sepsis program, what change has made the biggest impact?
I would say that's the early identification and intervention in the emergency department. By applying a front end process that nursing drives when the patient first walks in the door in the emergency department, it allows the nurse to use information we're putting in the electronic medical record to start driving a process. When we first began our intervention in the emergency department in January of 2018, we saw a drop in mortality from 12.6% down to 8.2% just with our initial interventions.
Dr. Overstreet, as you think back through the last 4 years, what's the biggest change your team has made in terms of improving the care of patients with sepsis, and what's left to do?
It is notable that we have really changed the paradigm in the emergency department and across the health system from a let's test and confirm if somebody has sepsis to more of a I think this patient's at risk for sepsis, and let's get the ball rolling and let's begin treating early. I think that we will continue to get more and more support from technology in early recognition of sepsis. We will have improving medical record systems that will help us to identify patients at risk for sepsis. And we will continue to push the envelope on how quickly we can get treatments initiated to improve patient outcomes.
Want to thank you both for being here. September is an important month and thinking about how we might get better at treating sepsis. And we appreciate all the great information from the two of you.
Thank you for the opportunity, Dr. Warner.
Thank you for having me.
Thank you for joining us. Until next episode, stay safe and stay healthy.